Hey folks, Brandon Noto from emsbasics.com. I want to talk about some of the different numbers you can use to express the outcomes of a clinical trial, or really in particular the effect size of an intervention. And if you're reading studies trying to figure out how useful a drug or some procedure is, you're going to see these a lot. And the problem is you can express them in different ways with totally different meanings. If you don't understand what you're looking at, you can't compare them, and you can't really get a sense for how useful that thing is. So I'm going to use a couple examples from recent studies we've put up on the Digital Research Library. Here's one. This was an amiodarone trial. It's a randomized controlled trial where they took patients in cardiac arrest. They randomized them to receive either amiodarone or a placebo, and they saw whether they survived more. And I'll just cut to the chase and say that there was no effect on survival to discharge, which is really what we care about, and that's why amiodarone is not such a big deal. But just to illustrate the numbers, there was an effect on the people who survived to hospital admission. So let's look at those numbers. If you got amio, you had a 44% chance of surviving to be admitted to the hospital. If you just got the placebo, you had a 34% chance. So that looks pretty good. It certainly seemed like real numbers, and that was a significant difference. So how can we express this? How can we express the difference in these two groups? And what we're really looking at is the effect of the drug on survival. Well, the easiest, probably the most intuitive way, and it's one of the better ways, is what's called the absolute risk reduction. And all you gotta do is subtract this from this. 44 minus 34% equals 10%. So that is the AR, R, the absolute risk reduction. In other words, if you got amio, you were 10% more likely to survive to be admitted to the hospital. Simple enough. Unfortunately, what they report most prominently, and this is true for a lot of these studies, is a totally different number called the OR, or the odds ratio. And the OR for amio to survival to admission is 1.5. And how did they get this? Because intuitively it seems like if the odds are 1.5, you should be about 1.5 times more likely to get to the hospital. But we see that is not the case. It's not that large of an effect. So how do you actually get it? You got to convert from percentages into odds. And this is not easy. So odds are expressed as the people we're interested in versus the people we are not interested in. But percentages are expressed as the people we're interested in out of the total. So if we go back to the study, we'll see that there were 108 survivors in the amio group out of 246 people who got amio. And if you divide that, you get 0.44, or the 44%. And likewise over here, there were 89 survivors out of 258, which comes out to 0.34, or the 34%. Odds are different. They take the people of interest, the survivors, and place them against the non-survivors, the others out of the 246. So to find those, we're just going to subtract 108 from 246, which gives us 138. Good over bad. And likewise over here, 89 versus the non-survivors, which were 169. So the odds ratio is going to be this number over this number. And that's tricky as a fraction, so it's easiest to turn it into a decimal, which is like 0.7826 and like 0.5266, and that divided by that is right about 1.5. Now, what does 1.5 mean to you intuitively? I have no idea. If you look at enough odds ratios, you'll start to get some sense for what high and what low is. And if you look at likelihood ratios, which we talked about before in the context of diagnostics, it's the same thing. And that's why if you're taking something like 10% chance diagnostic probability and you multiply it by like a a likelihood ratio of 10, the result's not 100%. Because you got to go to odds first, and odds never hit 100%. So, use the jaundice eye when you see the letters OR. You will sometimes see along with it something else which is a little more honest, but still hard to understand. This is the relative risk reduction. And this is just, again, comparing these numbers. If you divide this into this, you would get a ratio between these. And you can call it a risk ratio, and there's a few ways of expressing it. Most useful for this one would actually be the inverse, 34 divided by 34, and it's about, 0.77. That's the risk ratio, or that's how much less likely you are to die if you got amio. And if we express the other side of it, we could say, oh, you're about 23% less likely to die if you got amio. And those are both very true. This would be called the risk ratio or the relative risk. This would be the relative risk reduction. And they're true, and this is when you hear people say things like, oh, yeah, you were half as likely to die, or 2/3 as likely. In this case, maybe about 3/4 as likely to die if you got amio, or about 1/4 more likely to survive. But that's not really true in the context of the patient. As far as the patient or you should be concerned, you're about 10% more likely to survive. So, if you're going to express something, what would be the best way? The best way is probably what's called the NNT, or the number needed to treat. This is the most intuitive. And all it is the absolute risk reduction expressed as a whole number. So it's just 1 divided by the ARR. So 1 divided by 10%, which is really 0.1, right, is 10. The NNT is 10, meaning if we treat 10 patients, 1 of them will survive who would not have. For 9 of them, there is no effect. They were going to die, and they die, or they were going to survive, and they survive. But for the 10th one, he would have died, but now he survives. That's the effect size. A very high NNT, like 1,000, means we got to treat 1,000 patients to save 1 person. A very low number means a very strong effect. If we have an NNT of 2, if we treat 2 people, we save 1 life. 2 more, another life. All right, so let's look at these again, different study, now that we get the idea. Okay, so this is Jacobs from 2011, and this was an epinephrine study. Patients in cardiac arrest randomized to receive either epinephrine or a placebo, and they looked at who survived. And this was survival to discharge, and they didn't quite show a significant effect, but ooh, it was close. And you'll hear this study talked about a lot because they almost showed that epinephrine saves lives. Not quite, though. But if you got epi, you had a 4% chance of surviving. Placebos had a 1.9% chance. So let's calculate the absolute risk reduction. Just 4 minus 1.9, and that is 2.1. So you had a 2.1% better chance of surviving if you got epi, which is small, but all these numbers are small. That's how it is in cardiac arrest, and it seems pretty legit. Now they, of course, give you the odds ratio, which in this case is 2.2. And don't get these mixed up, they just happen to be close together. But how do you come up with this? Well, let's calculate it. If you go back to the study, there were 11 survivors in the epi group out of a total of 272, and there were 5 survivors in the placebo group out of 262, which means that really, to get odds, there were 11 survivors versus 261 non-survivors, and 5 versus 257. So if you divide that out to get a decimal, it is 0.0421, and it is, what is that, 0.0194. And if you divide that by that, it is like 2.16, or rounds to 2.2. So are you 2.2 times more likely to survive? Well, no. You can kind of do what you want with this number, but it is hard to make sense of. Now, a little more honestly, what would be the relative risk difference? Now, we could divide 4 by 1.9. It's probably more useful if we go the other way. 1.9 divided by 4 gives us, it's about a half, right? It's 0.48 relative risk or risk ratio, meaning you are about half as likely to die if you got epi, or 53% less likely, the relative risk reduction. And that's true, but it's not really true in the context of the patient, because if you're the patient, you're not half as likely to die. You're maybe 2.1% less likely. And if you're wondering where the difference comes from, it comes from the fact that this is considering only the patients who could benefit, and this is considering all patients. And we know that most of the patients are going to die no matter what, or maybe they're going to survive no matter what. But before we give the drug, we don't know which group the patient falls into. Now, a little quirk of this you will notice. If we had calculated the other way to keep it consistent, 4 divided by 1.9, we get 2.1 as the relative risk or the risk ratio, which you see is very close to the odds ratio. And they say that these numbers actually converge if you're dealing with small enough numbers. And you'll see why. To get the percentages, we were taking the number of survivors over the total, whereas the odds are the number of survivors over the non-survivors. But if the numerator is small, they're not very different numbers. 261 versus 272 is not a big difference, which is why when we compare them, these are not hugely different. So odds and risk become very similar if there are few enough people in the numerator here. So that's why they say if it's small enough, then odds is a little more understandable maybe, whereas for larger groups, it's not. But either way, it's not really what we care about, which is the absolute difference. And you see here that absolutely there wasn't a big difference. But best of all, let's get the NNT. So our NNT will be 1 over the absolute risk reduction, which is 2.1. So 1 divided by 0.021, because it's the decimal, gives us 48. So the NNT is 48, meaning if we treat 48 patients, one person will survive who would not have. For 47 of them, if they were going to die, they're still going to die. If they were going to survive, they will still survive. But for the 48th, we save a life. A big effect, no, but in the context of medical treatments, this is pretty good. Aspirin, for instance, is a similar NNT, and we know that aspirin saves lives. So, especially for cardiac arrest, where it's small numbers no matter what, and most people are going to die, this is not bad. And, if it had been significant, this would have been a really important study. So, when you look at any of these studies, these are things I want you to think about. I want you to look at what they're giving you, which is usually the odds ratio. Sometimes they give you a relative risk. But think of those and then think about what you really care about, which is probably the absolute risk change, or ideally the NNT. And sometimes they give you that. If not, you can calculate it yourself. But that is the most intuitive number for patients and also for you to get a sense for how effective, how powerful is this thing we're going to do. So think about it. Any questions you got, throw them out here. Brandon Noda from EMS Basics.